between 1998 and 2004. My interest in education and training started when I was in medical school. I was the student union representative, mainly for welfare issues. While a higher surgical trainee during my SPR training between 2011 and 2017, I was a member of the STC, which is the Surgical Training Committee, and I was also the core curriculum lead once I passed my FRCS exam. In 2015, I was awarded the Watson-Jones Prize for the third best performance in the FRCS TR North exam, and this year, much to my surprise, I was nominated for Trainer of the Year by BOTA, which is the British Orthopaedic Training Association, the results of which will be available or declared in December this year. Historically, the medical training in the UK up to 2007 was called the Kalman system, which was mainly time dependent. All relied on the number of hours or the number of years you spend in training. As a result, doctors spent long hours at work and had very frequent on calls, and pretty much followed the concept of, especially in surgical specialties, see one, do one, teach one. There was an annual review, which is the RITA, which is a record of in-training assessment, which is a paper format, which is mainly the yellow and the green forms. But the training assessment wasn't very structured, and it was very much dependent on a word of mouth. If your trainer thought you were good enough, then, and you had a good reference on your yellow and your green form, then you will most likely progress and continue until you obtain your CCT, which is Certificate of Completion of Training. There were lots of issues and concerns about the Kalman system. This was addressed publicly, addressed in a number of medical journals, and this has culminated in the reform of medical training in 2007 and the introduction of MMC, which is Modernising Medical Careers, and MTAS. The difference between the Kalman system and the MMC is that the MMC is competency-based, so it doesn't really rely on the number of hours you spend at work or the number of years. It's all to do with competencies, so you get assessed on a daily basis by different trainers, and depending on your competency achievement, then you can progress to the next level, which meant that most doctors had less exposure, because this coincided also with the EWTD, which is the introduction of the European Working Time Directive, which reduced the number of hours that a doctor can work to 48 hours per week. The assessment has changed from the RITA process to the ARCP process. And the ARCP is the Annual Review of Competence Progression, which is an electronic record. So you have an electronic, all trainees have an electronic record, which combines with their e-portfolio, through which they can log their activity, they can have assessment done by different trainers, and at the end of the year, you present your electronic record during the ARCP review, and the ARCP panel will decide whether you are competent to progress to the next stage or not. In between, there was the transition period, which was between 2004 and 2007, and the term, the lost tribe, became very popular at that stage, and I was actually part of that lost tribe because I graduated in 2004, so I was caught in the system. I graduated prior to the introduction of the foundation schools in 2005, when the FY1, i.e. Foundation Year 1 and Foundation Year 2, replaced the pre-registered house officer and the senior house officer, and then the ST training was introduced in 2007, which was the ST training versus the old specialist registrar training. So if you make a comparison between the old system and the current system, you can see the two columns that the current system suggests that you spend between 8 to 10 years in training, while the old system suggests that you spend between 7 and 9 years in training before you actually become a consultant. I personally think this is a myth. I think if anything, you actually spend more time now in training before you obtain a consultant job. Because your training is competency based, it means that you may not achieve all the competencies within the 8 to 10 years that they specify in this table. And I think we found that recently, if anything, recent graduates are probably spending more time in training in order to achieve the competencies required before being signed off as a competent doctor, and for the GMC to issue their certificate of completion of training, the CCT. The current medical training in the UK, this is the current structure. So you spend between 5 and 6 years in medical school, afterwards you graduate with either MBBS or MBCHB. During these 5 years, you can actually do an intercalated BSc. That will make your number of years at medical school 6 rather than 5. You can also opt out to decide to do an MSc or an MRes, which is the equivalent of an MD, which will push your 5 years of medical training to 8. Once you graduate, you go to F1 and F2, which is Foundation Year 1 and Foundation Year 2. And if you have an academic interest, then you can actually incorporate that and you can apply for an academic foundation program. If you decide to just go ahead with a standard Foundation Year 1, Foundation Year 2, then you can progress to your specialty training. And depending on the specialty you decide to choose, the number of years vary. For example, in psychiatry, you need 4 years, while in surgical specialties, you need a minimum of 6. If you decide to incorporate research while you are a higher trainee, then you have the option of actually applying for what we call an academic clinical fellow, which means rather than taking out time completely from your medical training or your surgical training, you can actually incorporate research within your training program, which in essence makes you, it doesn't take away the time that you actually need to take time out and separate yourself completely from clinical training. You still have clinical commitments, but at the same time, you are kind of part-time clinical doctor, and then you are almost a full-time researcher. By the end of your specialty training, you obtain your certificate of completion of training, which is issued from the GMC. And then once you have your post-CCT, then you are eligible to apply for a consultant post. Depending on the specialty, most specialties these days will require a fellowship, a senior fellowship between the completion of your specialty training and obtaining a consultant post. The length of your fellowship depending on your chosen specialty, and it depends whether you want to stay within the UK or you decide to go overseas, but it's anything between a year to a maximum of 2. The NHS is constantly changing, and as a result, the training has changed as well. There's always been a battle between training versus service provision. The population within the UK is increasing, the demands on all NHS trusts is increasing, and hence there's always a battle between training provision and service provision. And now these days, doctors are also expected not to be only clinicians, but they also have to incorporate leadership and management skills within their skill set. You have the chance, if you decide to opt out, so you can actually opt out at any point in your training. You have to apply to the Deanery, and you can apply for an out-of-program experience or an out-of-program clinical training. An out-of-program experience, I've seen it lately, where trainees actually decide to leave medicine for a year or 2 and take a management role or a leadership role, either within the NHS or in the private sector. And the out-of-program clinical training is very similar to a fellowship. However, you do it halfway through your training rather than the end of your training, where you decide to go and do potentially charity work or clinical training outside the UK. Those of you who have read or have read any personal development books, you see the 10,000 hours rule, which is common amongst all these books, which means if you want to master a skill, you need to spend 10,000 hours at least. And that probably applies to surgical skills more than medical or skills within other subspecialties. But the 10,000 hours, if you divide the 10,000 hours across the number of years you spend in training, I think most trainees these days are probably only gathering between 6,500 to 8,000 hours. So there is a slight concern that current trainees are potentially obtaining their certificate of completion of training, but they remain slightly deficient in their skills. As I said, this probably applies more to surgery. However, medicine has a lot of practical skills, radiology now has a lot of practical skills, and so does GP, and to a lesser extent, those who decide to go down the psychiatry route or public health. The BMA has recently raised its concerns about the possible deficiency in training, and the BMA does argue that there may be a generational decline in the skill set of trainees once they complete their certificate of completion of training. Again, this is debatable. Some people will agree, others will not, but I think it's very multifactorial. Things have changed in the UK. Entry to medical schools have changed. Now there is a fee. I mean, when I entered medical school, it was actually free. So now there is almost a chosen sector who can afford to actually enter medical school. Training has changed. The introduction of MIS, minimally invasive surgery. Now there is very little open surgery. Now it's mainly laparoscopic and arthroscopic. To give you an example, when I was an SHO, and not that long ago, only in 2007, I was a general surgical SHO at Hillingdon Hospital, and at night as an SHO I would do a couple of open appendectomies. Now you speak to current surgical trainees, none of them has actually done an open appendix. Now it's all laparoscopic appendectomies, and most of the time from what I hear from colleagues who are in general surgery, you know, the consultant needs to come in, the registrar needs to be around to do a laparoscopic appendectomy, just in case you need to decide and proceed to an open appendectomy. Training has changed also. There's a lot of virtual courses now, so the introduction of artificial intelligence, simulation programs, simulation courses have also changed training. Training is now probably less hands-on, and there's a lot of distant learning, and you can actually do things at home, or you can do things when you are on leave. And even when you go to the Royal College for certain courses, they are mainly simulation-based now, rather than actually hands-on. And there's always the element of cost. Training is actually very costly. So I think the aim within the current government, or probably the BMA, is to produce more generalists rather than super subspecialists. I think medical training in the UK has also been affected by the pay. There has been hardly any increase in the pay for doctors, the current contract, and most recently the changes in the pension scheme. In summary, training is dynamic, it will continue to change, and there will always be a battle between service provision and clinical training. The NHS continue to cut the funding, but the way I see it is ultimately the trainee's responsibility rather than the trainers. So I think it's down to the trainee to make the training as rewarding as it can be. However, the prime focus should always remain the same. You should do no harm to the patient, you should do no harm to yourself, and you should try and enjoy it and have some fun. Thank you. We can probably take a few questions before we proceed to the other talks.
Not a question, it's comment. You said, see one,
do one,
teach one, and I had to kill one. This has to go.
Okay.
This is one thing. The second thing, do you think we should go back to the house officer job rather than spending 2 years FY1 and FY2?
Personally, I think yes. I mean, I graduated prior to the introduction of foundation schools, and I think the previous system was functional enough. I think it produced safe, competent doctors. I think if you really scrutinize the current system versus the old system, it's probably the same. However, the terminology has changed. So I think rather than FY1, now it's rather than a PRHO, now it's an FY1. Rather than an NSHO, it's an FY2. And rather than a senior SHO, now it's an ST1 or an ST2. But I think the training itself hasn't actually changed much, but however the terminology has changed and the number of hours has changed. But the hospitals remain the same. The NHS structure itself hasn't changed dramatically. I mean, I know there are financial losses on a yearly basis, but I think the NHS still continues to function. So whether we should go back to the old system or not, probably too late to go back. I think the government will probably have to go through another white paper and go through the parliament and change it again. So it's unlikely it will change.
Any plans for changes in the training after the Brexit?
Honestly, I am not aware. I don't think Brexit has, I mean, the way I see it, I don't think Brexit has had a huge influence on training. Not as yet anyway, but who knows? I mean, things may change. I don't think there are any current plans to incorporate Brexit and the way it will affect the UK onto medical training.
Why I'm asking this question is that in my experience, it's since they applied the 48 hours training initiative, the standard of training in the UK has gone down, and the trainees couldn't achieve the 10,000 hours.
Yeah.
When we used to work before the European initiative, it was the on-call was 1 in 2.
Correct.
Then, once they applied the European initiatives, it became 1 in 4 or 1 in 5, and you're not allowed to do more than 48 hours or whatever. And that has put the training to a lower quality. My experience with everyone, including my colleagues, our colleagues, both the Arabi or both the Iraqi, they are very well trained people, and all they need is the final touches, and they become very highly specialist experienced surgeons, because there is no limit to the amount of training. There are always chances. While you come with the current trainees now, and they do a couple of laparoscopic cholecystectomies with the help of the consultant, while the usual previous SHO used to do 5 appendicectomies or whatever it is per evening without even supervision. So I think this point is very important to be looked at, obviously, after whatever changes in the...
I think there's been a cultural thing, a cultural change in the way medicine is being taught. And I think that goes down from the beginning of your medical training. I mean, even in medical schools now, anatomy is taught very differently to the way I was taught anatomy. Now it's all cross sections, and they look at iPads, and there's no such, you go to the anatomy lab, but the anatomy lab is never as well equipped as it was only 10, 15 years ago. So I think if you want to change the training in the UK, I think you have to go back to medical schools onwards. I don't think you can just change the higher surgical training or the higher specialty training. I think there has been a complete shift or a complete change of culture in the last 10, 15 years. Sorry.
Thank you very much for the presentation. Just, I think that nowadays with medical, with the training, so any training, actually, we are now facing actually consultants coming to business, and we need to mentor them for the first 5 years maybe, because they are. I think the training is the standard is getting lower and lower and lower regarding the quality of work. I think we need to move, because these systems, I don't know personally, I believe that these are names every time, given like fashion, F1 or SPR or ST or whatever, because no one knows what they are doing. I think we need to move from ticking box to real training. The ticking box is a problem of UK actually, because it started from medical college, teaching the student not to learn, to tick the box. And this is a problem. Here is, I think, the biggest problem in just making the quality of training is low. And I think we need to find a system in the future, maybe, and there is a green shoot here in the medical college. They start to return back to the old curriculum, by the way, in some aspects. But I think they need to move to a system away from ticking the box.
Correct. I mean, with regards to current consultants coming through, I am considered to be a young consultant. I've only been a consultant for 2 years. The culture of having 2 consultants operating is now becoming very common. Where before, you're a consultant, you do it on your own, you struggle, you have to find your way out one way or another. And I think this has been, with regards to orthopaedics, this has been currently actually incorporated into GERD, which is Get It Right First Time. And the BOA does recommend that you should have 2 consultants operating on difficult cases or complex cases. Has it happened? Probably hasn't happened yet. However, the BOA now is encouraging it. And recently I've sat on a consultants interview panel, and again, one of the questions that the medical director has asked to the potential person who was getting appointed is, how do you feel about two consultants operating? Because that obviously takes away part of your privacy, because you know, being in theatre is kind of your own place. You don't want anyone else to be interfering with what you do. But I think the way the culture has pushed training, you may have to start into looking into two consultants operating, which will obviously have an impact on efficiency and capacity.
Just a comment, I totally agree with Dr. Nazar about the effect of the European initiative on the quality of training. Our SHO, we have 5 SHOs in the department, and if they do night shifts from 8 to 8, they take 3 days off after that. Okay, they can't do a catheter, and they are urology SHOs, so this has to change.
I mean, that's why I said the training ultimately relies on the trainee rather than the trainer. And I think it's what the trainee makes of their training. So European-wide Working Time Directive is, you know, you see it in your contract, it's 48 hours. But in reality, no one works 48 hours. I don't think any junior doctor, fair enough, they have the 0 days, and if you don't on call for more than 24 hours, then you have to have the following day off. But if you put the hours collectively, fair enough, some of them actually do work by the clock, and the minute it's 5 o'clock they want to leave. But I don't think that will produce the competent doctors that the BMA or the GMC have aspired to. And that's why I said earlier on, fair enough, if you look at the comparison of that table that I mentioned, which says that the current training should, in theory, you spend less time. That's why I said it's probably not true, because with the EWTD being incorporated into this, you won't get the 10,000 hours or the 8,000 hours or even the 6,000 hours you may need. Hence, it's the responsibility of the trainee to actually have them come in on weekends. I mean, and I've seen it sometimes, you know, junior ST3s and ST4s, because they can't do much themselves, they come on weekends where there is a senior registrar on call, just to firstly see a bit more and get more exposure, because the exposure is now, I wouldn't say limited, but it's definitely declined.
I just would like to mention about the anatomy.
Yes.
I was representing the right surgeon of England in the OSCE surgery, and in that exam, the lady came to get her the tibia, and she started to practice as a humorist.
I'm not surprised.
And that time I took decision and did 70% of the questions in anatomy.
Yeah.
You know what is the effect of that? My daughter went to the exam and she failed twice.
Hani,
Yes.
thank you very much.
No,
That's a wonderful
you.
talk. I think commenting on what you said and what Ahmed has said as well is the duty of the trainee to get the training, not the trainer to chase to train the trainee. Because now life have changed and changing very fast in fact. And trainee, rightly or wrongly, I think they are rightly, they want to enjoy life and are not like us. We used to be slaves for training. I used to spend most of the time even the weekend in the hospital for the purpose of training and do the service as well. Now things have changed, and the trainee training is a very difficult thing to do. It's not an easy. Although some of the colleagues sitting here in this room, I have trained them this many years with me, training them. So it's not an easy thing. You chase them for practical training, for research, for publication. It's not easy. And I'm pleased you say that. But there's another point here, in the training system, it's two-way training. The trainer assesses the trainee, and the trainee also has to assess the trainer. So it is two-way system. We are discussing here the positive and the negative aspect of the training in the UK, and we hope take this experience and the positive aspect of this to transfer what we can to do the training. Our colleagues from Iraq that's been here, now listening to this, to take what we can in a positive way, if we can in the future, to transfer this to training in Iraq. And thank you very much.
Thank you.